Good morning, welcome to In the Trenches. Today we're going to be discussing peripheral arterial disease. This is going to be a very short talk, primer on peripheral arterial disease. Point number one, the word peripheral vascular disease is really not a term that should be used. That could involve anything. It could be deep vein thrombosis, it could be vasculitis of the legs. When you're talking about atherosclerotic disease of the lower extremity, you refer to it as peripheral arterial disease. Now, to understand this, you really need to understand the anatomy of the lower extremity circulation. Okay, so this is the aorta. This will bifurcate in the common iliac. Then external iliac goes into the leg, external iliac goes into the leg, internal iliac goes deeper inside. The external iliac artery becomes the common femoral artery. The common femoral artery becomes the superficial femoral artery. The superficial femoral artery is not superficial, it's just called the superficial femoral artery, okay, which becomes the popliteal artery. And then you have the trifurcation, which is the anterior tibial, peroneal, and posterior tibial arterial circulation. This is the leg. You can divide peripheral arterial disease into inflow disease and outflow disease. Inflow is aorta, iliac, outflow is the femoral, anything down. Okay, it's important to make these distinctions. And before we go into detail, the two main causes of peripheral arterial disease are diabetes, especially long-standing diabetes, and tobacco. Most of these people are smokers, especially younger people, especially younger women with aortoiliac disease. They're usually smokers. These are the two biggest risk factors. And sometimes you could see this in the very elderly. Okay. The next point you need to realize is when you talk about symptoms of peripheral arterial disease, you talk about claudication. And often the claudication will help you locate the location of the blockage. Okay, so claudication means you have a patient walking, they walk a certain distance, they develop a cramp in their leg, they rest, it gets better. Okay, the way this works is you normally experience this sensation in the area right below where the obstruction is. So if a patient has a superficial artery obstruction, they'll have calf claudication, and that's the most common presentation. If somebody has aortoiliac disease, it'll be buttock claudication. I'm walking, I have a pain in my buttock. When I rest, it goes away. Now, you need to go well beyond that, but that's how you ascertain this. The important thing is that most of these patients don't have classical claudication. There's a lot of atypical pain that could be involved here. So you could clearly see claudication, but the absence of it does not mean they have peripheral arterial disease. Okay, the next important point you need to realize is these people die of heart attacks. That's the number one death. There was a major paper, I believe in 1992 or 1991. The author's name was Michael Cricky. Okay, and it showed that people with peripheral arterial disease, they die of heart attacks. Okay, this is systemic disease. Okay, this is systemic disease. Okay, peripheral arterial disease, most patients who have peripheral arterial disease, also coronary artery disease, and may have cerebral vascular disease, but this group of people have a more severe degree of disease, okay? And these people die of MIs. So when you're treating them, cardiovascular risk reduction is the most important thing. These patients need to be on high intensity statins, and they need to be on antiplatelet agents, okay? Most of them do not die due to gangrene. It is very, very important to realize that. Okay, now, let's go over how you diagnose it. Okay, there are different degrees of this. Ideally, you diagnose it via physical exam, and then you order non-invasive studies. Okay, first there's the ankle brachial index. Theoretically, it's abnormal if it's less than 0.9. However, a lot of diabetics, especially elderly diabetics, they have very sclerotic blood vessels, and their ABIs could be falsely elevated. And this is not the best diagnostic test. You start with that. Along with this, you could get something called PVRs, pulse volume recordings, and see if the pulse flattens out where it flattens at, and arterial Doppler there. So these are done in conjunction with each other. This was a board test. The first screening test is an ABI, but usually I have to go beyond that. This is making the diagnosis. Now, you diagnose stable PAD. Okay, you don't go right to intervention. Okay, you try and get them to stop smoking if that's an issue. Aggressive lipid lowering, if they're a diabetic, control the blood sugars, and antiplatelet agents. And there's some evidence that ADP blockers such as clopidogrel are better than aspirin. Okay, this comes from the Capri trial in 1997. Okay. Now I want to talk about another concept, critical limb ischemia. Now this is a minority of these patients, but critical limb ischemia is when you have a non-healing ulcer, rest pain with a cold foot, and although this isn't critical limb ischemia, lifestyle interference. These are the indications for intervention. Okay, most patients who need intervention, and intervention is done much more commonly endovascularly now than surgically. You know, years ago they did surgery, now it's intervention, it's endovascular, or a hybrid procedure. Most of these people have multiple blockages. It's multiple blockages. They may have inflow and outflow disease, and sometimes you may just work on inflow disease. And this area is much more amenable to percutaneous intervention than outflow disease. But people with critical limb ischemia usually have multi-level disease. And you know, it's not a single fix. You know, I guess once in a while it can be, but usually it isn't. What causes critical limb ischemia? It could be a couple things. Number one, with any type of acute limb ischemia, you have to rule out an embolism. So this could be atrial fibrillation, and you could get acute limb ischemia, and maybe they don't even have significant peripheral arterial disease. The other thing is just progressive disease. Okay, and what happens? The pathophysiology here is different from coronary disease, where you have layers of thrombus forming on an occlusion, and some of it could break off and go distally. And there's also evidence via the COMPASS trial that maybe low dose factor 10A inhibitors like rivaroxaban could prevent major adverse limb effects. So, you know, when you're talking about acute coronary syndromes, you're talking about major adverse coronary events, you know, MI, stroke, or death. Major adverse limb events, you know, loss of leg, amputation. So that's just something else to think about. How do you treat acute limb ischemia? There you need an intervention, be it surgery or percutaneous, but you're going to get a vascular specialist, a vascular surgeon, or a vascular cardiologist to be involved with doing that. And I don't want to go into detail with that since I'm neither of the two. If you have somebody who's stable, ideally the best thing is for them to be in a walking program, a supervised exercise walking program. And you can consider doing interventional work, and with also all the medicines I mentioned. Major landmark trial came out about 10 years ago, the CLEVER trial, compared intervention to supervised exercise. And basically it showed that supervised exercise improved treadmill walking time over intervention. Okay, and a few years later, about 5 years ago, the ERASE trial showed that the combination of intervention with supervised exercise actually did better than supervised exercise alone. Okay, now you don't have to intervene in all these patients, but a lot of these patients, they don't have critical limb ischemia, yet their claudication is affecting their lifestyle. Okay, so this is what I really, wanted to discuss. Peripheral arterial disease is the name of the disease, not peripheral vascular disease. It's part of the systemic process of atherosclerosis. These people are usually the sickest of that group. They most often die of heart attacks. Okay, subset of these people develop critical limb ischemia. You have to intervene right away. You have to work on risk factor reduction. You have to aggressively place them on statins and antiplatelet agents, and possibly anti-10A agents. The other point I should make for claudication, for inoperable disease, so there's distal disease, infrapopliteal disease, which is unusual. You really see that in three categories. Advanced diabetics, you could see infrapopliteal disease. People who abuse ergotamines, now that's not a common thing, and that might be something more for board tests. And also thromboangiitis obliterans in young men who abuse tobacco. Those are the things that cause infrapopliteal disease. But as far as drugs that improve claudication symptoms, the only thing that really does this is a drug called celestazol or Playpol, and that may improve walking. Distance. And with that, I'm going to stop. We are in the trenches. Thank you.